Yes, sir. Now we are on live. We are good to
Yeah,
go.
thank you. Good afternoon, doctors. Welcome to this webinar on the role of oseltamivir in flu management. This webinar, this webinar, as you know, is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993 with 30 years of excellence and 36 state-of-art manufacturing facilities. Heathrow Healthcare has 300 plus products in portfolio and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Heathrow Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world, and is Asia's largest API manufacturer. Has Asia's largest API manufacturing facility at SCZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation, has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antiviral, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which, in August 2020, Heathrow Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar role of oseltamivir in flu management. We have Dr. Pramod sir as moderator, and Dr. Anil M.U. as speaker, and Dr. Nageshwar Rao as speaker. Welcome all the doctors. Dr. Pramod sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee member GAVI CSO 2016 to 19, Chairman Mini Recipe Module of IIP, author of book Cophology. Dr. Anil M. Sir is MBBS MD Pediatrics with Fellowship in Pediatric Critical Care, Diploma in Allergy and Asthma. Sir is Lead Consultant Pediatric and Pediatric Critical Care from Sparsh Hospital, Bengaluru. Dr. Nageshwar Narayan Rao Sir is MBBS DNP in Pediatric with Gold Medalist. Sir is PGD MCH from Indira Gandhi National Open University, New Delhi. Sir has clinical experience in NICE Hospital, Hyderabad, Mahavir Hospital and Research Center, Hyderabad, Mahadevappa Rampur Medical College, Gulbarga, Karnataka. Dr. Nageshwar has trained undergraduates from Care Hospital, Hyderabad, trained postgraduate DNB students, trained nurses in NRP and neonatal nursing protocols, trained staff nurses in PICU, faculty stroke instructor of pediatric advanced life support. Dr. Nageshwar has performed several procedures both in neonates and children and has presentation in many seminars and conferences. With this brief introduction, I hand over the session to Dr. Pramod Zoom. Over
Thank
to you,
you.
sir.
Thank you. Are my slides visible and am I
Yes,
audible?
sir. Yes, sir. Yes, sir.
Thank you. Thank
Yes,
you.
sir.
So we have an interesting session today related to the use of oseltamivir in flu management. And I'm glad to have Dr. Nageshwar Rao from Bidar and Dr. Anil from Bangalore to have this particular panel discussion. And we will be discussing a lot about influenza and management of influenza with special reference to this molecule oseltamivir, which is one of the antiviral agents. As we all know, there are very few antiviral agents oseltamivir in the management of viral infections in children. And it's important that we know everything about this particular molecule and when to use it and many other things related to the molecule and the disease. Everyone is aware that influenza is a virus which changes its structure every year. And that's because the amino acid sequence in the glycoproteins on the outer side of the influenza virus changes every year. These changes are not very great, minor changes. That's why they are called as, drift. And that's the reason why every year the influenza vaccine which comes into the market also contains different strains. And these strains, they get their names from the year of origin and the place of origin. And that's why I just put my name in the fashion of the influenza virus, which shows the place of origin and the year of origin and so on and so forth. And I was the IIP president in 2016. So I always say that I was the presidential strain of IIP in 2016. We'll be seeing more about influenza and oseltamivir in the course of today's discussion. And we are aware that influenza basically occurs more in the monsoon season. As it is, there are many viruses which create problem in the monsoon, and parents are really worried. The only entities who are happy in monsoon are the farmers and the frogs. And of course, our medical fraternity to a great extent is happy because the number of illnesses is more, and the pharma is also happy because the sale of the medicines is also more. However, for children, this season is very troublesome. And in some parts of our country, like north and extreme south, the monsoon comes at a little later date. And that's why in the months of November and December, the season for influenza, is there in these areas. We have also known that some other viruses like RSV, is seen on the higher side in monsoon, and arthropod-borne diseases like dengue are also more common in monsoon. So many times it becomes a diagnostic challenge while we treat a child coming to us with fever. And as I was trying to tell you about these viral infections, what we should know is that during COVID times, the infections were on the lower side because everyone was indoor. And that's why adults as well as children, they did not develop immunity against certain viruses. And that is what is called as immune debt. And that's why after COVID, the incidence of some of these viral infections started increasing. I remember in our state of Maharashtra, in some areas where measles vaccination was not very good, the measles cases they started rising because during COVID times the immunity was not obtained by children. RSV, hand foot mouth syndrome, and then this adenoviral infections, they all started increasing after COVID was on decline. And what we saw was even older children, they started getting affected in the post COVID period. And let us start the discussion of today's topic with this 3-year-old boy who presented with fever, cold, cough, and progressive breathlessness over 3 days, who was nicknamed with hypoxia like ARD. And the child was admitted to the PICU, was ventilated. He received oseltamivir along with supportive therapy, and the throat swab showed H3N2 positivity. Now, this particular child was given oseltamivir after he entered the PICU, and of course, this child improved after ventilation for 3 days. And that's why, when we started discussing, about this oseltamivir, there were quite a few questions. Whether a previously healthy child present with cough, cold, and fever, and progressing over 3 days, whether a treating clinician could prevent this particular progression to the seriousness by early use of oseltamivir, particularly in the flu season. This is more so important when, in certain areas where the facilities for the throat swab may not be handy. And that's why it's important that we are clear about certain confusing points about flu, which I call as confusing points. And then, there are many points which are confusing. For example, when a child presents, whether this infection is bacterial or viral, whether, this virus is rhinovirus, adenovirus, or influenza virus. If it is influenza, whether it is H1N1 or H3N2, and whether I should start oseltamivir. So many questions are there in the mind of our pediatric colleagues. And we are all aware that in monsoon, influenza-like illnesses prevail, all of them present with cold, cough, and fever. However, this influenza is the father of all those influenza-like illnesses, which we call them as ILI. And that's because influenza produces many systemic presentations like headache, high fever in the beginning, maybe with chills. The child might have leg pain, weakness, and even, an older child of 10 or 11 years is lifted by his father and brought to the OPD. Many times that makes us suspect that this is influenza. And I remember our teachers telling us that influenza being a respiratory virus, if all these symptoms are there and onset is with cold and cough, always suspect influenza. And many times dengue also comes in the season of monsoon. So he used to tell us that, see, in general, dengue is not a respiratory virus, and that's why If there is a child who comes with high fever, but there are no respiratory symptoms, you may keep dengue at the back of mind. Of course, some of these things may not be 100% truths, but then there was a point in what he was trying to tell us. This influenza, has been on rise, and the mortality is also, increasing. This virus is of three types. There is influenza A, influenza B, and influenza C. Influenza A is the one which is responsible for majority of the problems. All those pandemics which have occurred till now are because of influenza A, and it is also responsible for minor antigenic variations producing, drifting problems every year. And it is interesting to know that on the outer side of this particular influenza virus, there are two glycoproteins, HA and NA, and HA, hemagglutinin, is called as the molecular key because that is the one with which this virus gets attached to the respiratory epithelial cell, and the RNA of the virus enters into the respiratory epithelial cell, also known as the host cell. Inside the host cell, these RNAs, they replicate. In fact, the viruses are known to dictate the DNA of the host cells to produce similar copies as themselves. So many RNAs are produced which are called as virions, and these virions are rather cut literally like a scissors by an enzyme called neuraminidase, which is there in this particular virus. So this neuraminidase is the molecular seizures, and all those RNA virions, they are now ready to get out of the respiratory epithelial cell, and when they get out, they will infect other respiratory epithelial cells. And oseltamivir is the one which blocks neuraminidase. That's why it is called as neuraminidase inhibitor. And this is very important, to understand the further points related to the molecule. So what we should know is that influenza A is the one which is responsible for the periodic pandemics. Influenza B is the one which infects only human beings and produces local epidemics. But influenza A infects the birds, animals, human beings, and in fact, a virus from the bird and a virus from the human being, if it mixes in a third party like a pig, it produces a novel influenza virus which happened in 2009, and a totally new virus comes in circulation against which the community doesn't have any immunity, and that's the reason why a pandemic spreads. As I told you, these major global pandemics have been in 1918, 1957, 1968, and 2009. Dr. Anil, I would like you to just tell our listeners as to what is your impression about the epidemiology and the circulating strains of influenza viruses affecting the pediatric populations in India.
Yes, sir. Thank you, sir. Good evening, everyone. So this season, I think we went through a major flu season right behind us. The first spike is over. Usually, the first spike of the flu happens starts with the monsoon. So end of June, July, this monsoon starts, and so does the flu season. And typically comes down just before the winter. And during the winter, we do see a small spike of flu cases again, which starts up. So we are in the second spike of the flu cases right now. So this season we were having quite a bit of the epidemic of the flu also, and also we were bombarded with lots of RSV this season. So these respiratory viruses, flu, RSV, adenovirus, rhinovirus, these kind of viruses are more predominant towards the second half of the year. That's what we should know. And like sir has already given us the KYC of these viruses. So typically, similarly, what we saw is more of influenza A, less of influenza B is what we saw in this season. Again, in the influenza A, the subtypes, when we look at it, we saw more of H3N2 variety. And yes, of course, H1N1 also we did see. So what we typically saw in H3N2 is more severe variety, children coming with sudden onset of severe high-grade fevers and all that was there. And H1N1 also caused quite a bit of problems in this season. Influenza B we did see, and in this, I think we should be aware that only the Victoria lineage is seen. The previously what our flu vaccine contained, it also contained Yamagata strain also of the influenza B. And WHO keeps monitoring this strain of these viruses. and the Yamagata strain has not been seen in circulation for quite a few number of years. So henceforth, I think even the vaccine recommendations have come out which say only to include the trivalent, that is only influenza A, H1, H3N2, H1N1, and Victoria lineage vaccines, I think, will be using henceforth. So I think this is what we saw. Predominantly H3N2 is what we saw in Bangalore. And when we speak to our colleagues across the country, I think the similar picture is there across the country.
Excellent. So we are now of prevalent, and this particular virus, basically, it's a respiratory virus and it spreads by droplets. And when a person sneezes or coughs, usually these droplets they land in the mouth or the nose of the people who are nearby, and then these viruses are inhaled from the nose down even up to the lungs. And as the incubation period is short, the clinical features they start very rapidly. And as we all know that viral illnesses spread so fast that within the family, the small little children, will spread to their siblings and then to the parents and to the grandparents. It is important to note that the flu is a disease which spreads mainly from children to the adults. COVID usually, as we saw, it spread from the adults to the children. And that's why in children, when we immunize children, they will, rather stop or at least spread the virus to a lesser extent. And that's why it is very important to treat influenza in children with priority. Dr. Nageshwar, I would like you to tell our listeners about the different clinical scenarios with which influenza virus can present in the pediatric population.
Yes, sir. Thank you, sir. In pediatric population, usually most of the kids do visit our OPDs with the parents complaining child is having fever, sometimes moderate to high grade. Along with that, if the child is older enough, then the child may be able to explain the symptoms like sore throat, malaise, headache, body pains, and all. They do have running noses, and some of the children do have a little bit of higher symptoms apart from these routine symptoms like delirious, dull activity, vomiting, abdominal pain, diarrhea. And if not treated early, if they report to the hospital after 4 or 5 days, some children do present with encephalopathy like features also, sir.
Right. Now, Dr. Anil, what is your impression about the presentations of influenza that you probably witnessed this year?
Yes, sir. Influenza being a viral illness can have a multi-system spread also, and majority of these are all in literature we see. But in practicality, what we saw is more of respiratory kind of involvement. If it was not picked up in the initial period, they went on to develop a respiratory progression, respiratory distress who are landing in the ICU. Neurological complication is what we see generally. Because of the high grade fever, we saw babies getting increased febrile seizures, febrile encephalopathy, febrile status epilepticus, and very rare complications of necrotizing encephalopathy also. And also, yes, in literature, myocarditis, other systems like CVS complications like myocarditis, liver failure, renal issues, all have been described. But I think these are all very in advanced cases where it goes out of control if it is not treated. In practicality, we see more of respiratory and neurological complications more in numbers, sir.
Right. And I recently read a report where it was reported that children who had not received the influenza vaccine, the problems which you just mentioned were seen more commonly. They got influenza, but they, did not go into these severe complications. Now, let us come to, some important points related to the emergency signs in children. So, Dr. Nageshwar, when your child is brought to you with respiratory infection and when you suspect influenza, what are the emergency warning signs that you usually look for and which you inform the parents about?
Coming to infants, usually the parents come with a history like child is dull, not able to feed, and if at all little bit of force feeding is done, they do vomit or unexplainable or unconsolable cry, and altered sensorium. These are usually commonly seen in infants. When coming to children of little bit of older age group like toddlers and older children, then they usually present to hospital with fast breathing or difficulty in breathing. Sometimes they do have peripheral cyanosis. Along with that, when few questions are asked to the parents, they tell that child is not having food, child is not drinking any water or milk, or the child is not as playful as it used to be before this illness. And there is usually sometimes it is associated with rash also, along with the high grade fevers.
Sure. Dr. Anil, do you have any additional inputs to what Dr. Nageshwar said?
No, sir. In the interfebrile period, how active the child is, how good the oral intake is, general well-being of the child. These are the warning signs that we look at. Systemic wise, also we can tell them if at all respiratory wise any fast breathing or shortness of breath is there, or too much of lethargy, drowsiness. These are the general warning signs that we look out for.
Right, right. It is important to note what Dr. Nageshwar and Dr. Anil have told, because influenza is basically a biophysic illness, and many times in the beginning, it's possible that parents take the illness very casually when you say it's likely to be flu, because in general, people feel that flu is nothing but a bad type of cold, and child will probably come out of it. But you must inform them that it is necessary that after 3, 4, 5 days the child rather is observed properly, and at home please at least look at the respiratory rate, and if during sleep if the child is grunting, or if the child is rather having high fever, then please report to the casualty or to the emergency department. That is very important, because many times parents are known to take these illnesses very lightly, and many times they are afraid of going to the doctor or pediatrician again. Many of them, who are poor, they are worried about the, fees also. Many times, after 4 or 5 days, they feel that if I go to Dr. Jog again, whether he would charge me again, and, is it really necessary to go? So they will prolong all these, things to 1 or 2 or 3 days. And we all know now that it's a rapidly spreading virus, and that's why parents must be told clearly. So the complications of flu are best understood by putting them in the alphabet form, the alphabet being A. So a child can have complications like ARI, acute respiratory infection, like pneumonia, which could be primary viral pneumonia related to the influenza virus, which destroys or creates a problem with the respiratory epithelium, or it could be ARDS. These could be related to the cytokines released in the course of the illness. And then a child might have acute otitis media, because these viruses, as they disturb the epithelial flora. These bacteria like pneumococci and staphylococci, they get an easy access onto the respiratory epithelium, producing secondary bacterial infections. And all this leads to absenteeism from the school, and parents also lose their daily wages or the income. And as the picture of these respiratory infections is confusing for a practicing clinician, many times there is antibiotic abuse. So all these are important points, and that's why it is necessary that we know that there is something like a classification of influenza disease. And Dr. Nageshwar, will you like to tell the listeners about categorization of influenza into categories A, B, and C, so that our listeners are clear about the management in the latter part?
Yes, sir. For the ease of starting the treatment, we usually divide the category of patient into A, B, and C. Usually, the children who are included in category A are who have presented with a history of mild grade fever, cough, mild throat congestion, with or without body ache, headache, diarrhea, and vomiting. Usually, little bit of uncomplicated viral infections, we consider them as under category A. Again, coming to the category B, here, this includes the patient who have presented to the hospital with very high grade fever, severe throat, sore throat, along with the category A symptoms. In the category B, we also include children who are at high risk, or a special group of population who are less than 5 years with a pre-existing illness, who are on steroids for a nephrotic syndrome or any other diseases, or a child who is less than 2 years, malnourished children, pregnant women, and elderly patients like the grandparents of the child, like who are above 65 years, who might be having some underlying cardiac or any lung or kidney related or neurological related issues. Along with that, some of the immunocompromised patients secondary to infections like HIV, or who are on long-term cortisol therapy, or even chemotherapy patients. These are the group of patients who we include in category B. Coming to the category C, this is the group where we include severe, early sick children, like who has presented to the hospital with the acute onset of breathlessness, chest pain, drowsiness, along with hemodynamic disturbance in the form of low blood pressure, CFT is prolonged, or the child is in the impending respiratory failure, where he needs immediate ICU admissions. So this is how we categorize children into category A, B, and C.
So now we are aware that there are some categories which are based on the seriousness of the illness, and we will be going to the management based on these categories. Just before that, I will give you a quick information about this molecule, oseltamivir. And as I told you earlier, it's a neuraminidase inhibitor, which is critical in releasing the virions from the infected host cells. So it blocks the viral neuraminidase enzyme, and basically it's a prodrug, and it is converted into the active form oseltamivir carboxylate in the liver. And this was the first oral neuraminidase inhibitor, and it has been approved in more than 100 countries, approved by CDC as well as American Academy of Pediatrics. And based on these categories which Dr. Nageshwar told us, I would request Dr. Anil to explain the management of these children based on these categories.
Yes, sir. So category A is our routine OPD kind of patients. The patients who we would see in the OPD, they would come to the OPD. And these would be the mild category of symptoms where they'll have a mild cold, cough, coryza, body pain, headache, myalgia. For such children, routine just home isolation, I think we should emphasize on isolation, not to go near the high risk patients like anybody who is aged or young age group. And also adequate rest, hydration, paracetamol, symptomatic care is good enough. We really don't have to test these category A kind of patients, nor treat them with the specific antivirals like oseltamivir. Category B is the moderate kind of patients who probably would require a little bit more care. Probably if they're eating and drinking can still be managed from ward, but here I think managed from home, or they would require, if it is little more severe symptoms, would require hospitalization for supportive care. So definitely this category B would require prompt starting of the antiviral therapy, preferably within the first 48 hours. And of course, provide a good supportive care like hydration and taking care and monitoring is very much required. Category C are the ones probably with the red flag signs, what Nageshwar sir has described just now. These are the category of patients who would require immediate hospitalization based on their severity of symptoms, either to the HDU or if it is very severe, maybe in the ICU also. So these are the ones again prompt even empiric antiviral therapy is required for these set of patients, and of course rigorous monitoring and supportive care is a must for these kind of patients. So category B and C, definitely testing will be required, and also the antiviral will be required.
Sure. So the understanding of the categories and the management will help us a lot in the management of these children. And the dosages and the recommendations for oseltamivir are important. And in adults, the dose is 75 milligram capsule twice daily as a part of therapy, and 75 milligram capsule once daily as a part of chemoprophylaxis. Usually, this chemoprophylaxis is given for all those high risk, people in the family. When a child is having influenza, it is better that we protect the high risk individuals in the family so that they do not progress into serious complications. In children, the dosages are dependent on the weight bands, and in infants, the dose is 3 milligram per kg twice daily for therapy. And later on, depending on the weight band, up to 15 kg, up to 23 kg, 40 kg, above 40 kg, the dosages they change. The thing is that the treatment is given in the twice daily dosage, while prophylaxis is given once in a day, and prophylaxis is given for 10 days. The syrup of oseltamivir is available with 12 milligrams per ml, and depending on the weight, one can always calculate the amount required for the child. Dr. Nageshwar, it is always discussed that we have to start oseltamivir early in the course of influenza. So, how does early initiation of oseltamivir influence the clinical outcome and duration of illness? Will you just tell our listeners about it?
Yes, sir. Yes. Usually, oseltamivir a drug we usually consider in category 2 or category B and C group of patients. By the time if we start oseltamivir early, like within first 48 hours of onset of disease, then there are various studies which shows that it reduces the duration of the illness by 1 to 2 days. Hence, when the duration of illness is decreased, along with that, there is a proportional decrease in the risk of complications which can occur in children like pneumonia, encephalitis, or secondary bacterial infections. And whenever the complication risk is low, definitely the chances of hospitalization are also less. So hence, early treatment is associated with better recovery and fewer long-term sequel if we add oseltamivir early in the part of treatments. But if some patient do present to us a little bit of late, like fourth or fifth day also, then oseltamivir can also be started at that time. Studies have shown that even if you introduce little bit late also, it reduces the disease severity and it can help to prevent complication to some extent.
Right. It is very important to note all these important points. And there are many studies wherein patients who were brought little late to the emergency, even in respiratory distress, when they were put on oseltamivir, the further complications and the mortality came down. And this has also been proved by quite a few clinical trials, wherein it was proved that oseltamivir treatment of influenza reduces the lower respiratory tract complications, the antibiotic use, and the hospitalization. And this is true for children as well as for adults. And even WHO has said that empiric treatment is strongly recommended, and the treatment should be started as soon as possible. And laboratory confirmation of influenza virus infection is not necessary for initiation of treatment. To such an extent that if one suspects influenza clinically, and if the laboratory test for H1N1 comes negative, it is even then prudent and wise to give oseltamivir, because there are some conditions or situations where the child might have influenza, but the test may not be positive. We will discuss a bit about the tests in a short while. We will just see certain cases so that some of these points are clear. Dr. Anil, there is a child who has come to us for fever for 3 days with cold and cough, and this child has been on metered dose inhalers since 4 months. He is well controlled. He has received symptomatic treatment, but he comes back after 3 days. He has been only half febrile for a day, and the child has again got fever. So the parents are worried, even though he has been active in between. We have seen so many cases like these coming for recurrence of viral infections, which have become more frequent and occurring at shorter intervals. So we would like you to give advice about antibiotic therapy and as to how would you counsel the parents of such children.
Yes, sir. I think this scenario has become very common to us of late, especially after COVID, because of the phenomenon that you explained, sir, about the immune debt, in the sense children were not exposed to much viral infections. And now suddenly, when the toddlers and the school growing children, they're exposed to these viruses, they keep getting these viruses on and off. So it becomes difficult. The parents are also extremely anxious and they want answers, and they keep coming to us with these minor cold coughs and all that. I think giving that 2 extra minutes to these parents, making them sit down, asking them what is their anxiety issue, or like what stresses them out too much, and all that, spending those 2 extra minutes will help us. Of course, we'll do a thorough clinical examination, plot the growth of the child on a growth chart, reassure the parents, showing the growth chart that your child is growing fine. And it is normal for any toddler or preschool child, or when they start the school for the first time, to have 8 to 10 viral infection, upper respiratory infections in a year. It is very common. That's a child is learning the immunity. As and when the child is growing, there is no ready-made immunity that we can offer to the child. So the immunity has to be learned. We give the example of COVID, tell them whenever a new virus is there, a new infection is there, it's natural for somebody to go through this. And I think we can counsel them this way. And in fact, many a times we do tell them, please consider common cold as a part of your family member. So who will be along with your child till they're around 6, 7 years of age. So we'll kind of reassure them, telling that we are always there. You can always come back if there's any concern. Of course, explain them the red flag signs. And uh, I think somehow we need to try to counsel them not to come under pressure and prescribe recurrent antibiotics. We'll also explain them the antibiotic abuse and the side effects of all these things. And I think that should do, sir.
Yeah, thank you. Dr. Nageshwar, do you witness such patients in your OPD? Because, at some major cities and metros like Bangalore or Mumbai or Kolkata, there are quite a few, educated and super educated parents who are always worried about all this. But then maybe at places like Bidar, where I assume that the parents are not that inquisitive. Do they ask you such questions, or they simply accept whatever you do from your end? What is your experience in general?
Sir, we do get a mixed group of population, sir. Here, we usually where I practice, there are we usually come across all type of patients. Again, our approach will be based on the parents, whether they are like like from a village or from a educated background. Along how because of their how they can accept the things, we'll try to counsel them like that, sir. Even there are a few scenarios where they get to us along with the antibiotic. So when the child doesn't require an antibiotic, we explain them and we ask them to stop the antibiotic and continue with only symptomatic therapy, sir. For parents
Okay.
who are educated, we do take some more time to counsel them and explain the facts so that they are convinced with our counseling.
Yeah, thank you very much. This particular aspect of this discussion is very important because, of late, whenever I see the prescriptions and whenever I discuss with many colleagues, giving antibiotics has become like a reflex action for many of our colleagues, unfortunately, and, simply, when a child gets cough, cold, and fever, not much of time is devoted to history, examination, and counseling, and antibiotics are given just at the drop of the hat, and that is something which is not a good state of affairs, and we should all introspect and decide whether this particular child really needs antibiotics, because we are all aware about the antibiotic resistance, which is growing very rapidly. We will discuss this point again after a little while in connection with some other case. So it is also important to identify that this particular illness is viral. And some of the viruses like rhinovirus, they produce only problem in the upper respiratory tract with simple cold, where may not be any fever. The child will be otherwise hale and hearty, playing well. Children with flu might have, rather severer symptoms like headache, myalgia, and exhaustion. And of course, adenoviruses, though they are primarily respiratory viruses, they produce different sort of presentation in some children, like pharyngoconjunctival fever, diarrhea, mesenteric lymphadenitis, or hemorrhagic cystitis. And infants under the age of 2, particularly under the age of 1, they get this RSV infection, which produces bronchiolitis. And some bacteria, we can have an educated guess. For example, a child with follicular tonsillitis with tender cervical nodes, one can suspect group A beta hemolytic streptococcus. Pneumococcus can produce pneumonia, which can lead to fever, grunting, and staph can produce rapid progression, and child would be much more toxic. Mycoplasma, of course, affects relatively older children and presents predominantly with cough. Okay, this was another child, and this was 4-year-old with cough and high-grade fever since 5 days, not settling with oral medicines. And on admission, the child had tachypnea and needed oxygen support. The total count was 1620. Platelets were 132,000, and liver functions were deranged. And nasopharyngeal swab, showed S3N2 positivity. He was diagnosed as a case of influenza with low WBC and the low platelet count. This is also a common scenario in the daily practice. And Dr. Anil, I would like you to analyze and dissect out this particular case so that our listeners would get a proper approach when a child like this comes to the OPD. Yeah.
Yes, sir. Ours being a little referral center, I think we do get such referrals quite often and patients coming to us on day 4, day 5. So straight away, syndromic classification, when we are seeing the child, so this will straight away land up in category C kind of illness, acute febrile respiratory illness with tachypnea, probably requiring oxygen, means sick enough to be categorized as category C. So empirically, we would go ahead and start this child on the symptomatic supportive care with oxygen, all these things. And but along with it, with the backdrop of these monsoons or in the flu season, we go ahead and start them on empirical oseltamivir. We would draw blood cultures and start this child on antibiotics, IV antibiotics also. Probably a few hours later, 1 or 2 hours later, we'll get the initial blood reports and all these things, which will again kind of narrow down the scenario. Here, I think leukopenia, total counts being 1600, platelets also being on the borderline side are more towards it being a viral etiology. So our suspicion of it being a category C influenza-like illness, I think it kind of validates that assumption that we made. And also, if you look at this scenario, transaminitis is there. SGOTPT is moderately elevated. So especially in the monsoon season, and there may be an overlap of dengue, in the sense there may be a coexisting dengue which is going on in the community. So we should not be forgetting the possibility of dengue fever. And in this scenario, probably it's worthwhile to do a dengue test, either ELISA or the rapid test, depending on the protocol that we have, to rule out dengue fever. And of course, nasal swab, whenever it is available for category C kind of patients, we should go for a nasal swab to be done. It may be a standalone flu panel, or a multiplex PCR also can be done depending on the availability and affordability of the patient. So this is a classic case that we would get and would fit into the category C, and management in these broad lines, we should take care of this patient.
Excellent. Of course, the suppression of the WBCs and the platelets is related to the bone marrow suppression, which is produced by these viruses. Dr. Nageshwar, in such cases, when you don't have the facility for swabs and the reports coming very fast to you, what is your practice usually?
Once the child is admitted into ICU zone, again, priority will be again airway breathing and circulation. Once this is settled, again we'll go for the treatment of the etiology. As we know, like child with a history, we'll come to know like child is sick since 3 or 4 days, since 5 days. So we'll start with, as a child is tachypneic, we'll start this child on oxygen. If oxygen supplementation is not sufficient, we'll go for non-invasive modes of ventilation initially, sir. Along with that, IV fluids to maintain the hydration, antipyretics, antibiotics are also will add, sir, in view of the low platelet count. Again, as sir said, we'll do all the necessary investigations and proceed with the treatments.
And I'm sure you will also give oseltamivir empirically, because
Yes,
it
sir.
is something that we discussed. Great. This was another child who again came with H3N2 positive throat swab. Another child again with H3N2 where the counts were normal, but the CRP was on the higher side. And then another child who deceived us because, this turned out to be adenovirus positive. Of course, one of the clues was that he had high WBC count and high CRP of 136 and had continuous high fever. During this season, we saw quite a few children who came with lobar pneumonia and turned out to be adenovirus positive, and one of them was human metapneumovirus positive. This is a girl, 5-year-old with high fever for 5 days, cough and cold for 5 days. The child is sick, has mild wheeze. There are no crepitations, and this is the presentation. So, if such a child comes to you, Dr. Nageshwar, how would you approach? Initial approach based only on the history and examination.
Fine, sir. This child will advise hospitalization. Once hospitalized, we'll start the child with the IV fluid, sir. As the child is sick, we'll look for a GRBS. In view of mild disease, we'll look for vitals. If there is a relative hypoxia, then we'll start with oxygen supplementation also. IV fluids, and IV antipyretics. Along with that, we'll start empiric antibiotic, and in the history of like ongoing epidemic of viral infections or epidemics, we'll start this child on oseltamivir also. As the treatment progresses, we'll reassess the child frequently, and based on the symptom, we'll try to modify the treatments.
Okay, so this child was put on amoxiclav. The WBC count was 2800. CRP was 34.7. The child was put on oseltamivir also, but the nasopharyngeal swab showed rhinovirus positivity, and that was something which made us discuss about the sensitivity of these influenza PCR and the treatment decisions. So, Dr. Anil, would you like to give a few details about the PCR tests which are done these days for detection of the viruses?
Yes, sir. The latest generation of PCRs are quite sensitive. If it is performed well, that is, the swab is taken from deep within the anterior nasopharynx and also from the throat, then the sensitivity is pretty good, more than 95% chances that it will pick up the virus if it is there. So at the same time, the specificity is also pretty good. So if it is negative, means it is negative. So the specificity is close to even 100 many a times. So in this situation, when the multiplex PCR is done, which detects other viruses also, there may be a chance of us detecting more than one virus. Like in this scenario, rhinovirus has been detected. So when it is detecting more than one virus or a unexpected virus, so the clinical syndrome is this child is sick on day 5 and sick looking child, we wouldn't expect a rhinovirus to be there because rhinovirus is a limited spread. It's a locally, it causes only rhinitis, mild myalgia, mild fever, and it gets better. So it is not fitting the clinical picture. But the other counts, like total counts, are there, and the CRP is moderately elevated. So, and with the backdrop of influenza, if there is an epidemic in the community going on, probably here we would think about it being probably the sensitivity, it's not picked up the flu. And if the clinical syndrome is fitting into a clinical picture of a flu-like illness, it's worthwhile to continue 5 days of oseltamivir and complete the treatment rather than stop in between. The rhinovirus may be just a co-infection or any bystander which has been picked up in the PCR panel.
Okay. Then this is another child, a 7-year-old daughter of IT sector parents, came for a high fever for 3 days with throat irritation, and this child had examination in the school after 2 days. So the parents were worried. The throat showed mild congestion. The child was prescribed paracetamol, and in view of the flu and the adenovirus cases going around, the parents wanted to know whether there is a need for investigations, need for a throat swab, and whether any need for empiric oseltamivir. So when such children come to us, because in Bangalore, I'm sure, Dr. Anil, we have so many parents from IT sector. So how would you, approach such children?
Yes, sir. This is again, I think the categorization, systemic categorization will help over here. We know that fever of 3 days, throat irritation, otherwise a well child will be still in category A. I know like the extra pressure by these parents, with especially with the exams around the corner, they may ask us for further testing or antibiotics and for us to do more. Always they push us to do more than what is required. I think better not to succumb to those pressures. We would approach it again systematically by the categorization. This would still be a category A, so we spend that extra time with these parents and explain them this is still category A. We will revisit the child in the next 24, 48 hours if there is worsening, explain them all the red flag signs and call them back. And I think we should not, if it is not indicated, better not to get into the CBC and all these other things. If at all the parent is too pushy, probably will ask for a throat swab, which will be done, which will help us also to know empiric what is happening epidemiologically. We'll get to know by doing a throat swab. So if the parents are very pushy, wants answer, probably I'll ask for a throat swab and wait for it. In the meantime, empiric oseltamivir also, since it is category A, we can withhold. If there is a proven case somewhere in the family, yes, we can treat this child empirically. But if it is just out of suspicion, may not be required to start in this particular scenario, sir.
Okay, thank you. it's always very important, to deal these parents carefully. I remember, recently child was brought by these IT sector parents, and on examination, in fact, the child did not have fever also. So I asked them, what are you worried about? They said, no, sir. Every time when we check, he has fever. He has fever. So then I asked them how you measure the temperature. So what they were doing is, for all the recordings in the temperature, somehow somebody had told them that add 1 degree to whatever temperature is recorded in the axilla. So they were telling me the figure after adding 1 degree centigrade to that. So I told them that is not done, and every area of the body has a definite temperature record, and don't add 1 degree centigrade. So these people have their own views, and many times it becomes difficult to convince them, but it is important that we take a little time out and tell them about some of these things. And Dr. Nageshwar, this was a child, a 3-year-old boy, came for cough for a week and high fever for 3 days, had crepitations, was put on co-amoxiclav, and was admitted for persistent fever. And he was put on IV amoxiclav. The counts were almost normal. The CRP was also in the normal range. And the throat swab was sent, which showed influenza A positivity. And that's why oseltamivir was also added. Now, in view of this particular situation, what would be your approach, and whether you would continue the antibiotics or whether you would stop the antibiotics? So, what are the points on which you would decide the decision to continue antibiotics or withdraw them totally, or how would you look at this situation?
In this case, child was already started on IV augmentin, and there is a history of cough for 1 week, followed by high-grade fever for 3 days, sir. There were crepitations also. Uh, so once the child is clinically stable, and we got the biofiber test as influenza positive, and total counts being normal, it is prudent to continue oseltamivir and stop antibiotic in this child, provided the child is well nourished and is not falling into any malnourished or severe acute malnutrition groups.
Sure. Now that you said about this severe acute malnutrition, I'm sure you must be getting these children with SAM, with mid-arm circumference less than 11.5 centimeters and all. So in general, for respiratory infections, is your approach different than healthy children at your end?
Yes, sir. In those children, we give a little bit more time to ask few more questions. How the child is in between the fever spike. Once the child gets any infection, in how many days it used to get recovered previously. Along with that, we'll go for a detailed physical examination to look for signs of any anemia or any signs of kwashiorkor or marasmus, sir. Along with that, after once we prescribe the treatment, we also counsel the parent like this treatment is just to decrease the symptoms, but the child may get repeatedly infected if the immunity is low. So once the child recovers, you please visit back to the hospital so that they get a nutritional counseling, and also monthly or bi-monthly visit to monitor the growth and improvement in the child's conditions.
So I think it is very important that the management of such children is more comprehensive, wherein you tell them about nutrition, vitamin A, and trace metals like zinc. Even some people say vitamin D. They need to be supplemented to these children because these repeated infections are known, and today the child might be relatively okay, but the next episode might be with some severe infection, and the child might have serious problems. So it is necessary that the parents are told about comprehensive management. It's very important. In fact, one of my teachers, used to give vitamin A, to those children who were malnourished, at least one dose, because, at that time, vitamin A was not a routine in the government program. But then, I remember Dr. Udani from Mumbai, who used to say that a child who is malnourished is as if sitting on the camel hump, and then we don't know when that child would get malnourished, and when he would become blind. So that marginal vitamin A deficiency, he used to call it as blinding corneal malnutrition. So it was a corneal malnutrition, and BCM was the term. when you were discussing about this, I just remembered that. So it's important that the management of such children is comprehensive. And of course, during this season, we have had a few cases where CNS was involved. And Dr. Anil, now that you are so close to the ICU situation, this 1-year-old child came for fever, cough, cold, and status epilepticus. The nasopharyngeal aspirate showed H3N2, and MRI showed non-specific encephalitis changes, and the CSF was normal, and he was labeled as a case of influenza encephalitis. So, I would like you to tell our listeners a bit about the neurologic complications of influenza.
Yes, sir. After the respiratory complications, second most complications we see will be the CNS kind of complication. So, because of the high grade sudden onset fever, we have seen increased incidence of these febrile seizures, simple febrile seizures. Sometimes they land up in febrile status epilepticus also. Little older children, especially boys, adolescent boys, and they land up with acute febrile delirium because of the high grade fever, they become delirious and they improve with just symptomatic supportive care. They do improve. We do see lots of cases of aseptic meningitis. We are suspecting meningitis, even the LP doesn't show anything, and they also improve very well. Uh, Very rare complications also we did see this year, like acute necrotizing encephalitis. So this is a situation which is immune mediated because of the cytokines, and the CSF may be not showing a cellular response, but the MRI will pick up these changes like in the deep nuclear, like the thalamus, we do see central necrosis also. And GBS, it can induce GBS and sometimes GBS mimicking kind of a situation also because of the peripheral nerve and the muscle involvement can be there because of intense myalgia. We have seen few cases of GBS and GBS mimics also in this seasons.
Okay. There have been quite a few cases with additional RSV infection in some of these children who came for influenza. And as we discussed a bit about some complications earlier, it is also known that chronic pulmonary conditions like asthma, particularly in children above 2 years, are exacerbated by influenza infections. And there are reports of toxic shock syndrome as a complication of influenza, cases of myocarditis. So it's important that when a child is being monitored, you look at the pulse rate, and whenever the pulse is disproportionate to the degree of fever, it is important that you look out for myocarditis and other parameters. Myositis is known, particularly with influenza B, in boys who are 6 to 9 year old, who have bilateral gastrocnemius and soleus involvement. When they come with severe bilateral calf muscle pain and inability to walk, whether in myositis or for fever, one should never use aspirin group because it is known that Rye syndrome is precipitated by use of salicylates in children who suffer from influenza B. There are a few quick questions. And Dr. Nageshwar, there are two children in the family. One is, 8-month-old and has influenza A with LRTI. And the younger one gets again, fever. So what we do about oseltamivir? Do we start for the younger one?
Yes, sir. Because younger one, again, the age is less than 2 years, and it is proved that it is influenza A. This comes into better to start the oseltamivir in this child.
So in the contacts who are in the high risk group, particularly children under the age of 2, it is always desirable to put the child on oseltamivir. Dr. Anil, what is your opinion about chemoprophylaxis to the household contacts?
Yes, sir. Chemoprophylaxis is important in the high risk group. Anybody who is aged less than 2 years or more than 65 years, or they have chronic medical conditions like a chronic asthma, like a COPD in the older age group. They have diabetes, or there is any kind of immunosuppression because of chronic rheumatological conditions, renal conditions. I think these are the cases where we need to start the chemoprophylaxis. But at the same time, indiscriminate usage for the healthy young adults should be discouraged.
Yeah. It's important to understand that in a family, at a given time, it's possible that, the father is diabetic or the mother is pregnant or the grandparents are asthmatic. And when a child suffers from influenza, many times, the others in the family are neglected. Many times one doesn't remember, even our pediatric colleagues must remember that when a child is brought like this, and if at least when the throat swab is positive for influenza, it is desirable to take a history. And in the family, if there is someone from the high risk category, just to see that they receive the chemoprophylaxis for 10 days. So we have seen that this influenza is a fast and a furious virus with abrupt onset and high transmissibility, rapid progression, and in some children progressing even to ARDS. And that's why we also have to be very quick in administering oseltamivir. In addition, it's important that we prevent influenza by following certain measures. And we all are aware of SMS, that is sanitization, mask, and social distancing, and cough etiquettes, which include coughing in the elbow, and also some important rules, the sutras related to the hand, which I call as Hasta Pancha Sutri, which includes frequent hand washing, avoiding handshakes, using handkerchiefs, keeping others and contacts at a hand's distance, and avoiding hand touching. The virus spreads not only through respiratory droplets, but also fomites. So it is there on the top of the doorknob, on the staircase, on the top of the laptop, everywhere. So it's better that you are careful about all these areas, because the spread can be prevented. So it's also additionally important to see that you yourselves as practitioners and your staff members receive flu vaccine every year. Many of us who are above 40, 50, 60, they are in the phase of immunosenescence. The immunity is going down. And that's why, if influenza occurs, we all now know the high risk conditions. Some of us could be diabetics, hypertensives, asthmatics, and it is better to get ourselves protected with whatever rate of protection, 60%, 70% with this flu vaccine against flu. And that's why at least on the happy birthday, when people say happy birthday to you, always remember that you yourself at least say happy birthday to flu, so that you yourself, get yourself protected. And annually, only one shot of flu vaccine is required. So it's quite possible to prevent flu and its complications by timely use of oseltamivir and vaccine whenever you come across children and also the high risk people. So with that, we come to the end of this particular discussion, and I always feel that we must follow our tradition of saying namaste and rather avoid handshake, so that at least from our part we reduce the spread of these viruses to others. Thank you.
Thank you, sir. Thank you so much.
Thank you, sir. Thanks, Dr. Nageshwar. Thanks, Dr. Anil. Thank you, sir. As usual, it was very informative and interactive. I'm sure the audience has benefited. Thank you so much. We can log off. Wish you a very pleasant evening. Thank you.
Thank you, sir. Thank you so much.
Thank
Thanks,
you.
Bhuvan. We can log off, Dr. Anil. Dr.
Yeah,
Nageshwar.
thank you, sir. Thank you.